Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith-Rogers. Today, rural health. Dr. Cara James is the president and CEO of Grantmakers in Health, a support organization for philanthropies across the country. She speaks with Dr. Josh Sharfstein about the crisis in rural health and where philanthropies are trying to make a difference. Let's listen.
Dr. Cara James, thank you so much for joining me today on Public Health on Call to talk about rural health. Let's start with an introduction. How would you introduce yourself to our listeners?
Well, thank you, Josh, so much for having me. I would introduce myself as Cara James. I am currently the president and CEO of Grantmakers in Health, where I've been for 4 years. And before that, I was the director of the Office of Minority Health and co-chair of the CMS Rural Health Council at the Centers for Medicare and Medicaid Services, which is in the Department of Health and Human Services.
So Grantmakers in Health, what is that organization?
So Grantmakers in Health is a 40-plus-year-old organization that's called a philanthropy support organization. So we help foundations, and we work with more than 200 foundations across the country, learn, connect, and grow through educational programming, convenings, reports, surveys, and a variety of activities to network and learn about different issues like rural health.
So I imagine some of these foundations may be huge foundations giving out lots of money, and others might be kind of small, maybe family foundations, some of which might be tied to rural communities.
Absolutely. So we include in the Grantmakers in Health family foundations that I'm sure everybody knows, the Robert Wood Johnson Foundation, Kellogg Foundation. But yes, a lot smaller foundations that could be 1 or 2 person foundations in communities that are rural, local, place-based organizations. So, and everything in between.
I once saw the schedule of one of your conferences, and it was really interesting. It covered so many different topics, and I kind of imagined in my mind's eye that people who are on boards of foundations were showing up to figure out what's going on in the country and how they can make a difference.
Absolutely. We have, and it is exactly as you said, we have programming for trustees, for exactly as you mentioned. We do programming for CEOs. One of the sessions we love is what's keeping you up at night. We have programming with communication officers and thinking about how the communication officers at foundations can leverage their voice to do more than promote the work of the organizations, but also to help move work forward around issues like equity or other things, and programming on specific topics like rural health, maternal health, and other topics.
So let's go to a conference of yours on rural health. And first of all, when you have a session on rural health, how do you define rural?
Well, that's a great question. There are a lot of definitions of rural. I don't know that we have a specific one. So you said, let's go to a conference. Well, the good news is you can. We have a conference that we have done jointly with the Federal Office of Rural Health Policy and the National Rural Health Association for over 10 years, where we really are diving deep into issues around rural. But we also, at our larger annual conference that we have each summer, have some sessions on rural. So that could be, for example, looking at this year's conference on rural philanthropy focused on the workforce, a big issue that you will hear a lot about in rural communities. Other ones have talked about mental health, opioid, and other issues. So that's kind of what you'll see in a lot of people who are trying to develop partnerships and work on implementing ideas in their communities.
And so it sounds like people may use different definitions of rural in order to show up at a conference like that. But what would just a little bit of a flavor for the kinds of communities we're talking about?
So these communities are varied. They are, by definition, smaller. And that's where you get into that variability of how small. So we have frontier communities that could be very large geographic areas with just a few people. And you have other areas that may be just smaller geography, but still fewer people that are there. They may or may not have a hospital. They may or may not have other services, roads, geography, time is something we think a lot about, travel time in rural communities. But they can be your snowbird communities. Think about the ski resort communities. They could be your reservations for American Indians and Alaska Natives, and a lot of other things in between.
So it must be hard, given that variability, to give an answer to this question, but I'm going to ask you anyway, which is, how would you characterize the state of rural health right now in the United States?
That is a complicated question, but I think the state of rural health varies. There are some places where we have hospital closures that are happening and people are losing access to services, nursing homes that are closing. We have others where there are economic struggles, where people are, in many cases, having housing issues, those sorts of things. An older population tends to be one of the things we consistently see across rural communities. Some communities that are becoming more diverse as immigrants are moving in or people are leaving urban areas, and that's what we saw in the 2020 census. And then there's some communities that are doing very well and thriving. And so it's a bit of a challenge, but overall, it's a community that tends to be sicker, that tends to be older, that has challenges related lower incomes than some of their urban counterparts.
There's a word that often gets used with respect to rural communities and health, which is despair. Suicide rates are higher, overdose rates for a long time have been higher. At the same time, the mental health system is weaker, services are harder to come by. How does this challenge play out in the kind of work that you do, or from your vantage point?
It plays out in a number of ways. I think you see foundations that are helping to provide access in whatever way that they can for some of those services, supporting programs for opioid use disorder. So we have foundations that are specifically set up, honestly, to address the opioid response. That are others that are trying to support telehealth and make sure that people can have access to mental and behavioral health services. There are other foundations working through schools to try and make sure that our youth have the supports that they need in their community and the programs that they're trying to do. So I think you see a lot of variability, and what you see in many of the foundations is trying to do something that addresses the particular needs of their community. So no one size fits all.
Now, in health and in public health, we're very aware of the connections between underlying social factors and health. And that is certainly true in rural areas. Like if a big company moves away and there are no jobs and the young people are leaving, then despair may soon follow. And you can certainly provide more access to clinical care, which is really important, but you're not, if you just do that, addressing some of those underlying issues. So how do you see the relationship between rural health consequences and rural health causes?
It's huge. I think you mentioned some of the big ones in terms of the employers. One of the biggest employers in a rural community is the hospital. And so if that closes, that can be a harbinger of other things to come, because you may then lose other employers because it's hard for them to attract workers. I think that relationship, and philanthropy understands that, because you see the myriad ways it's working in education, in housing, in transportation, all of those things that can help to provide the community needs, as well as community engagement and sort of power building in communities to come up with those resources. We see scholarship programs to try and get training programs for youth in rural areas and to other places, planning for rural training tracks to support residency programs in rural areas, because we know if we train our providers in those areas, they're more likely to stay there. So I think that connection is very well understood, and also can be challenging to address because the workforce. I
wonder if we could talk for a moment about race and ethnicity in the context of rural America. When some people think of the picture of rural America, it's sort of like a white family on a farm. Is that a fair picture these days? And how do issues of equity play out in discussions of rural health?
It's a great question. I think that is definitely the perception of what rural communities look like, but it's changing. And we have seen with the census, there has been some growth in diversity. It is still predominantly white in rural America, but it also varies where you are. 90% of rural Blacks live in the South. So that's a different picture than, say, in the Midwest or in the Plains in terms of that diversity. In terms of how equity plays out, again, it varies. In some cases, and even in our rural philanthropy meeting, we had someone say, we can't really say health equity. That doesn't sit well in our community. So there are different ways to think about it. And in terms of many conversations, I would say when I first started in this space, when I was at CMS, rural health equity was rural urban. There wasn't necessarily the intersection of race in that conversation. But I think as a result of the pandemic, you're seeing more of that happen and more understanding of what's happening and some of the opportunities and challenges, because the growing diversity means communities may need to think about language services in a way that they had not before. But when we think about where people live and the needs that they have, there's opportunity and challenge there.
I also wanted to ask you about trust. The pandemic, as you mentioned, exposed a lot, including a huge trust gap that was particularly pronounced in rural areas where fewer people were vaccinated, for example. More people believed untruths about vaccines and other aspects of the virus. Is that considered a hot topic in discussions of rural health these days?
Yes. Well, as you know, misinformation, disinformation, and distrust is a big issue and something the Surgeon General is focused on. And we've seen a decline in local media in rural communities and in other places, and that contributes to that mistrust and distrust. So you are seeing just this past fall, a number of foundations came together and are working on increasing information as in those areas to support that and to counter some of the misinformation that is there, so that we can build more trust and get people the information that they need. It's hard in this world of social media with instant information that is not necessarily easily countered, but it is something that is of interest in a growing number of foundations who are focused on that, and critically important if we're trying to have policies, have programs that are health promoting and working towards what we need. And also our ability to work together on these issues.
So I wonder if we might end with like a example that you can think of a foundation that has really been focused on rural health and is finding ways to make a difference.
The one thing I'm going to say, and this is going to be a little Pollyannish, there are a lot of examples out there, so it's kind of hard for me to pick one. But one of the ones, we do a rural health road trip each year. And this past year, we went to Montana. And we got to see the work, particularly I'll point out some of the work that the Montana Healthcare Foundation is doing with tribal health leaders in the state and bringing them together to help them create and design the health systems that they want to have for their tribal community. So they've supported leadership travel to Alaska to see the NUCA model and have brought that back as one example. I think also in that space, we saw Headwaters, who's working at kind of the high line of Montana, bringing people together to support, again, workforce issues around how to increase workforce in rural areas. Those are just two from just one example. I could name a number of other ones, like Benedum, Mary Black down in South Carolina, who's looking at behavioral health and the needs that they can do there. So there's a lot of work being done in these communities. We need a lot more because philanthropy, like a lot of things, is a little more urban centric. And so more resources are needed to help rural communities achieve their highest level of health. And that's part of what we're trying to do, is to get more foundations engaging in the rural communities.
Well, Dr. James, this has been a fascinating conversation, incredibly important work that you're doing and all the foundations that you work with in rural areas to really address critical gaps in health.
Thank you so much, Josh. It was great chatting with you.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, Produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Grace Ceciri. Audio production by J.B. Arbogast, Holly Cardinale, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Ceciri and Eliza Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.